If we look at what we have in the oral presentations, so one of the big things in the mantle cell lymphoma population was the SHINE study, which was a phase 3 randomized trial looking at the BTK inhibitor Ibrutinib combined with the chemotherapy regimen Bendamustine and Rituximab versus Bendamustine, Rituximab, and placebo. So this phase 3 study, which was conducted over a course of around 7 years, demonstrated that the combination itself of BR plus Ibrutinib did have a progression-free survival benefit over BR plus maintenance Rituximab alone. The question mark is that there was no overall survival benefit, and in some of the high-risk patient populations we see in mantle cell lymphoma, the blastoid pleomorphic variants, patients with high-risk MIPI, and those who have a P53 mutation, we didn't really see a substantial difference in outcomes between that and the standard of care arm, which would be BR alone. So that really calls into question to some, is there a benefit to giving these drugs combinationally as a combination, or whether they would be better given in sequential order where patients would get BR and then in the second line setting get a BTK inhibitor. So the study wasn't designed to answer that question, and so I guess it'll be left to, if this treatment combination does get an FDA approval, it will be less up to the investigators to decide how to best administer this in this patient population, which in itself was designed to give it to more elderly, frail patients who typically would not be candidates for more intensive upfront therapy. Additionally, in an oral session, they did discuss long-term follow-up of the ECHELON-1 study, which evaluated the combination of Brentuximab plus AVD versus ABVD. ABVD had become the quasi-standard of care in the US for treating patients with Hodgkin's lymphoma. And so with the initial ECHELON-1 study, we did see some benefit in what they considered the modified progression-free survival. Further follow-up did indicate that progression-free survival benefit for the combination. Some hesitancy with using the combination, especially in the US, came with the cost of using Brentuximab in this upfront therapy and some of the supportive therapy such as GCSF that was needed to keep these patients from getting infections due to their neutropenia. But now with this most updated finding of an overall survival benefit in this patient population, AAVD will likely become the new standard of care for advanced stage Hodgkin's lymphoma here in the US, irrespective of some of the negatives that were pulled out, meaning cost and infection risk. Given the young patient group, the overall survival benefit is likely to try to trump some of these negatives because, again, most patients with Hodgkin's lymphoma are a younger patient group when you look at compared to some of the other non-Hodgkin's lymphomas. So when you're talking about patients in their 20s and 30s, ideally, if you are able to keep these patients alive, it sort of accounts for some of the cost differences that will come up with our historical standard of ABVD.